All right, so let's get started. So again, for those of you that just recently entered and don't know us, my name is Kaitlyn O'Connor. I'm Senior Counsel with Nixon Gwilt. If you aren't familiar with Nixon Gwilt Law, we are a healthcare innovation law firm focused mainly on working with innovators in the healthcare industry. So everything from innovative healthcare providers and practices to software and device companies that service the healthcare industry. And also we've got a practice in the life sciences sector as well. We're super excited to be here. Carrie's the managing partner. She'll introduce herself in just a second, but Carrie and I work together along with Rima and Faisal, who you also see are in as panelists, to lead our firm's remote patient monitoring practice. I always like to say that my career has kind of grown along with remote patient monitoring because I joined this firm back in 2018 when remote patient monitoring first became available for standalone reimbursement. So we kind of know all there is to know about it, and we love to share our knowledge with you all. So thank you to everyone that is here already and to those that I think are still trickling in. For those of you that are here but may have team members or people you know that couldn't make it, we are recording. So just know that it will be available. This will be available on the website and on our firm website afterwards if you want to reference back to it later on or share it with anyone else that wasn't able to attend. All right, Carrie, do you want to introduce yourself and talk about how people can ask questions?
Sure. As Kaitlyn said, I'm managing partner of Nixon Gwilt Law, and I am delighted to be here with Kaitlyn and Rima and Faisal. They are I think, the nation's leading experts in remote patient monitoring and virtual care at this point, and I am really fortunate to have them on our team here at Nixon Gwilt Law. We will go ahead and get started. I'm seeing some questions in the chat box about the recording being available. Kaitlyn has just mentioned that we will make the recording available as shortly after as possible. The slides themselves are not going to be available standalone, but you will have access to the recording. So we'll go ahead and get started with, there we go, with the typical legal disclaimer. This webinar presentation is designed to provide information to the viewer. Nothing in this presentation or the accompanying slides should be construed as legal advice to any individual or entity and is not provided in the context of an attorney-client relationship. Further, nothing in this presentation should be construed as a guarantee of reimbursement. I feel like I was just on an airplane as a flight attendant doing the here's your safety notice. So anyway, we've gotten through that. Let's actually dig into the substance here. Our agenda today is going to be one that is tailored largely to people who are somewhat familiar with remote patient monitoring. We're gonna assume sort of a baseline understanding of what remote patient monitoring is, and a little bit about the reimbursement infrastructure around it. If you are brand new to remote patient monitoring, don't worry. We have another webinar that's more of an intro to RPM, and I think you will still find some very valuable information here. Would love for you to follow up with us after the webinar if indeed you are new and are looking to get started in remote patient monitoring. So we're going to do just a very high-level overview of the RPM codes, followed by some of the very important clarifications and changes to RPM in the 2021 Medicare Physician Fee Schedule. We're going to touch on the intersection between the FDA and remote patient monitoring. And we're going to talk a little bit about a privacy and security framework for RPM. Importantly, we're going to be discussing some market trends that we have been seeing in the industry. And we're gonna wrap into the conversation a little bit about care management services, telehealth, and virtual communication codes as well. Finally, we'd like to talk a little bit about some of the new business model opportunities that have come about as a result largely of the changes to the anti-kickback statute and Stark law, and what those may mean for digital health and for remote patient monitoring in particular. And if we have time, we will open it up for a little bit of discussion. All right, so for many of you, the CPT codes that you see on this slide outlining sort of remote patient monitoring are very familiar. The first three, CPT code 99453, 99454, and 99457, and then also actually as an add-on 99458, are sort of your classic remote patient monitoring codes that we see frequently in use today. The reimbursement amounts that we have put in parentheses here are general sort of national Medicare averages. We are seeing a variety of commercial payers reimbursing for remote patient monitoring. That includes Medicare Advantage plans, as well as just, sort of regular private commercial payers, the Cignas, Aetnas, Blues, Anthems that you see out there. The reimbursement amount for the commercials varies a bit. We are sometimes seeing reimbursement be, quite a bit above these averages, and sometimes it's a little bit below. So it's important to, be aware that there's not universal reimbursement tied to the RPM codes, but that you may need to check either with your local MAC or with your local payer representative to get a sense of what the exact reimbursement might look like in a particular area. But briefly, as we know, CPT code 99453 is really a one-time reimbursement code that is designed to take into account the time and effort spent in educating a patient around the use of the device that they're going to be using for monitoring and the use of the RPM platform, and helping them to get that set up so they can get off to a good start. CPT code 99454 is for supply of the device or devices that are going to be used in monitoring. A key thing to remember here, and a question we get all the time, is can I bill this code for each device I use for a patient? And the answer is no. This supply of device or devices code is a one-time per month code, regardless of how many devices you're using in the episode of care. CPT code 99457 and CPT code 99458 really cover the activity of the care management services around remote patient monitoring. It involves looking at the data that's come in, the patient-generated health data that has been transmitted. It involves interpreting that data, doing some analysis. If an abnormality is detected, reaching out to the patient and saying, hey, I see that your blood pressure has been really high over the past 2 days. Tell me a little bit about what's going on. And it's making some changes to a care management plan or coordinating with other caregivers or providers to make sure that the issue is addressed. 99457 requires 20 minutes of time during a calendar month of those types of care management services, an aggregate of those types of the time spent on those types of care management services. 99458 is sort of an add-on code for an additional 20-minute increment, or even 2 or 3 additional 20-minute increments. We always, sort of give the caveat that OIG would not really want to see a pattern of 3, billings of CPT code 99458 in a particular month for a bunch of patients. That would definitely draw a red flag. But it is designed to be used as an add-on code for each additional 20-minute increment spent on monitoring. And then CPT code 99091 is the one that I've listed last because it tends to be used the least, even though it was actually the first standalone reimbursement for remote patient monitoring. And that is because 99091 requires 30 minutes of time spent by the physician or PA or nurse practitioner, working with the data, analyzing it, interacting with the patient. And after the first year of that code, it was really, we heard from doctors who said, this is not useful to us. It is difficult for us to spend 30 minutes of time just looking at data. We really want to know just when there's an issue that we need to address. So the response to that was really the first 4 codes that you see listed on this page. Let's go to the next slide. I'm going to ask Kaitlyn to talk a little bit about this first RPM then and now slide.
Sure. Yeah. So just a really quick note about questions also. I'm not sure if Carrie mentioned this, but you can feel free to ask questions along the way, either in the Q&A box, or you can type them directly into the chat. Make sure that if you're putting them in the chat that it's coming to the panelists at least. And then you'll see along the way, Rima and Faisal are fielding some questions along the way. And then at the end, Carrie and I will address some of them as well. If any come up along the way that we can kind of tie into what we're saying, we'll try to address those as well. But either way, feel free to drop them either in the chat or the Q&A box, and someone will answer your question for you. Okay, so yeah, so now we're going to move into a little bit of some past and present differences between where RPM started and where it is now. And this is just to give everyone a good understanding of where we're going in the future, because up until 2021, we didn't really have a ton of guidance for the specific requirements that CMS was expecting with respect to billing these codes. So we want to make sure everybody's got that foundational knowledge of, where we were last year, just, like a month ago, and where we are now.
So just to build on that before Kaitlyn gets into the substance, 2021 has been a very big year, I should say the 2021 Medicare Physician Fee Schedule has been a very big deal for RPM, because in the past, people have been very reluctant, some physicians have been very reluctant to use the codes because they didn't feel like there was enough guidance around them. And this is the first time in the Medicare Physician Fee Schedule that CMS has made an effort to clarify some of the outstanding questions that were out there. They clarified some of them in ways that we appreciate, and they clarified some of them in ways that we might disagree with, and probably some of you do as well. But we're going to walk through this a little bit right now.
Yeah, absolutely. Okay, so let's start with probably the most well-known change that came about this year in 2021. So as Carrie mentioned, with 99457 and 99458, there is a requirement that 20 minutes of time be spent in delivering the services associated with those codes before the billing provider can actually bill them. And up until this year, the question was, what does that mean? What goes into that 20 minutes? And until we had final word from CMS, we all kind of interpreted that that meant all care management activities that were associated with RPM. So reviewing data as it came in, analyzing it, communicating with the patient, making treatment decisions, all of those services that go into a successful remote patient monitoring program, we assume could be included in that 20 minutes. For the 2021 Physician Fee Schedule, CMS proposed back in July of last year to say, no, that entire 20 minutes of time actually has to be spent providing or participating in an interactive two-way synchronous communication with the patient. Essentially, they said for that entire 20 minutes, the doctor or clinical staff has to actually be on the phone with the patient, talking with them about the data and about their condition. So Carrie and I, along with many of you that are in here right now watching this webinar, and a bunch of other stakeholders as well, went back to CMS and we said, that's not really appropriate. That's not practical. We need to compensate physicians and clinical staff for all of the time that they're putting into delivering these services, because they already don't have enough time in their day. So, making them do an additional 20 minutes of a telephone call in addition to everything else that goes into it really isn't fair, isn't practical, and isn't going to, and it's going to be prohibitive for patients and providers. So this is one area where Carrie mentioned we were very happy with what we got back from CMS. They took into account all of the feedback that we, along with other stakeholders, gave them and said, okay, you're right, that 20 minutes of time can include all care management services that are associated with RPM. So now we have final rule for 2021. We don't expect this to change anytime soon. That going forward, that 20 minutes of time that is associated with Cpt codes 99457 and 99458 can include all care management services, including the interactive communication that takes place with the patient, but also including all of the other services that go into that. So again, reviewing the data, analyzing it, making treatment decisions, etc. If you have more detailed questions about that, you can follow up with us, but that we felt was a very positive outcome of the 2021 physician fee schedule.
Yeah, this is exactly where your comments come into play, right? It really matters, the comments that you all submit to the proposed rule. Fortunately, CMS heard us on this one.
Yeah, and if you don't know the process for how that works, just a really quick primer, what happens is CMS releases a proposed rule in July, usually in the summertime, with all of the things that they are thinking about changing in the Medicare Physician Fee Schedule. Then they give us about 60 days to reply to those proposals and tell them what we think is good, what we think is bad, what stakeholders are seeing on the ground, because as you probably know, CMS doesn't have a lot of people on the ground actually doing these things. So it's helpful for them to hear a practical perspective. And then once they read through all those comments, they will come back with the final rule at the end of the year that tells us what the actual rules are going to be going forward. So when you hear us talking about passed versus proposed versus finalized, that's that process that we're talking about. So the second thing that was kind of a big deal in the 2021 fee schedule was the 16-day requirement. So for 99453 and 99454, the CPT code book and CMS, the fee schedule, say that in order to bill those two codes, at least 16 days of monitoring has to take place. And prior to 2021, we took a pretty loose interpretation of that and assumed that that meant as long as the patient was enrolled in a monitoring program for 16 days and providers were being reasonable in the services that they were providing and making sure that the patient was actually using the device, that would be sufficient, using the device for 16 days, that would be sufficient. We thought of it as more of a rolling 16-day basis rather than what was proposed and now finalized for 2021, which is that 16-day requirement now actually means that 16 days of data out of a 30-day period must be collected and transmitted in order for 99453 and 99454 to be billed. So I think the strictest interpretation of that is that that means a patient has to take 16 separate readings throughout the month or throughout the 30-day period, regardless of what is appropriate for their condition, in order for 99453 and 99454 to be billed. Now, in the proposed rule, CMS asked for stakeholders to provide scenarios where 16 days of readings was not required or not necessary for a patient. Things like weight loss or diabetic patients that were monitoring their weight, and a couple of other use cases where it's really not appropriate and sometimes bad for the patient to take 16 readings in a 30-day period. And CMS maybe didn't read that or didn't fully understand all the stakeholders' perspectives, because in the final rule, they expressed that they didn't see any legitimate clinical use cases where less than 16 days would be required. So they went ahead and finalized that 16 days of data out of a 30-day period. I will also just note that that 16-day requirement only applies to 453 and 454. So one of the questions we always get is, if the patient doesn't meet that 16-day requirement, but we spend 20 minutes of time or more monitoring them, can we still bill 99457 and 99458? And the answer to that is yes. That 16-day requirement does not apply to 99457 and 99458. So I'll pass it over to Carrie now to talk about some of the other changes that we see this year.
Yeah, and the one that Kaitlyn mentioned was very, very significant. The 16-day requirement is one that has caused people in the industry some pretty significant concern, because it can be difficult to get people to, especially if it's a device where they have to put it on and take a reading. It can be difficult to get someone to adhere for 16 out of 30 days. But CMS has made that determination. My recommendation to all who are doing remote patient monitoring is to make sure that you are collecting data and analyzing data so that we can demonstrate to CMS that valuable information can come out of less than 16 days of monitoring being transmitted in a 30-day period. That's just my recommendation. I'm hoping that there will be some change to that policy going forward, whether it's new codes or whether it's a different determination. We'll see.
Yeah, and I'll just add really quickly, because I see a couple people asking the same question, which is it 16 data points or 16 separate days worth of readings? And unfortunately, right now it is 16 separate days. So if there are 2 readings that take place in the same day, that's only going to count for one of those days. It's not going to count for 2.
Yeah, that if you look at the box on your far right at the bottom, it's 16 days of data out of a 30-day period. So that was specifically what the rule said. So, you know, we'll take it for what it's worth.
Right.
Okay, the next one is actually fairly significant as well. And it involves the data, how the data is collected and with what and how it's transmitted. So when these codes first came out, we saw a number of folks in the RPM industry using a SaaS platform as part of their remote patient monitoring, a SaaS platform that could push out questions that would allow patients to self-report particular indications, such as pain and such as mood. So for example, what is your mood like today? Are you feeling happy? Are you feeling really down? Or tell me what your pain level is like today. Is it a 2 or is it a 10? And the clinical providers were using that information as very relevant to how a patient was doing with their particular condition. And the interpretation had been that is patient-generated health data being remotely transmitted to a provider for analysis and interpretation. That was what we found was a very reasonable interpretation in the past. A lot of people took that interpretation. We believed it was reasonable. The 2021 proposed rule, however, basically mandated the use of a peripheral device with remote patient monitoring. So not only must that peripheral device be deemed reliable and valid, whatever that means, the data has to be collected electronically and automatically. It cannot be entered in manually by a patient. And it has to be transmitted, for example, by Bluetooth or cellular or Wi-Fi, rather than self-reported via the SaaS platform. We pushed back a little bit on that one, and actually quite a lot on that one, because we thought it was really important that patients have a way to indicate pain and mood and things like that that might not be measurable easily by a device. But for 2021, they did finalize the determination that the data must be electronically collected and transmitted rather than self-reported. Let's turn to our next one. And this one is, we get this question a lot as well. Earlier on, we saw that remote patient monitoring services were only allowed to be furnished to an established patient. So it was the case that a physician or a nurse practitioner or a PA had to have an established patient relationship prior to ordering remote patient monitoring for a patient. During the time of COVID here, we saw CMS release an interim final rule that waived that requirement. It said during COVID, we are not going to require that a patient have a pre-existing relationship with the physician before that physician orders remote patient monitoring. They wanted to be able to allow, establishment of a patient relationship via telehealth, and they wanted to just push care out there in any way that they can. So during COVID, they did waive the requirement, and that requirement is waived right now, where it is possible for a physician to, establish a relationship with a patient and then at the same time sort of order remote patient monitoring services. We had hoped that might stay in effect post-COVID, but they did propose to return to the established relationship criteria after the end of the public health emergency, the COVID public health emergency. And that has been finalized. So after the public health emergency has ended, RPM services may only be established or be furnished to an established patient. I will say that the rule is silent on whether you can use telehealth to establish a patient relationship. Certainly that has been the case during COVID. Previously, before COVID, Medicare did not reimburse for telehealth or anything around it without an in-person relationship previously established. You know, that is gone during COVID. And the 2021 rule does not specify that the established patient relationship has to be established with an in-office, in-person visit. So we're reading that to mean that establishing a relationship via telehealth is allowable. All right, Kaitlyn, you want to take the next one?
Sure. Yes. So, okay. So one of the other big questions that we have gotten over the years is who is actually eligible to order and bill for RPM services. As we all know, there are lots of different use cases for remote patient monitoring in various sectors of the healthcare industry. For instance, we know that in physical therapy can be very valuable, in internal medicine it can be very valuable, in cardiology, et cetera. We'll get into some more specialties later. But basically we know that there are lots of different use cases for this, but it was unclear up until this point who was actually allowed to order and bill for it. So one of the requirements for RPM generally is that it has to be ordered by a physician or qualified healthcare practitioner. What this means is that it has to be someone that is otherwise eligible to bill E&M codes generally, that orders and bills for the services. So this hasn't changed over time, but we've gotten clarification from CMS on it. So this year they said only physicians and non-physician practitioners who are eligible to bill for E&M visits can order and bill RPM services. There is a specific list of physicians and non-physician practitioners as far as CMS is concerned. It's typically physicians, nurse practitioners, physician assistants, and then a couple of others. This is quite limited, and I think that this is problematic and potentially prohibitive for a lot of patients that could benefit from remote patient monitoring. But as Carrie and I will mention a little bit later on, we have heard that there are some other code sets in the works that would open this up a little bit more. For right now, though, just keep in mind that physical therapists are not eligible to bill, podiatrists are not eligible to order or bill for RPM, and then other practitioners that might be able to bill some E&M codes or some CPT codes to Medicare, but aren't eligible to bill all of the E&M codes, like regular office visits and outpatient visits, are not eligible. If you've got more detailed questions about a specific provider, drop it in the chat and we'll try to respond for you. But generally it's physicians, NPs, PAs, and then a couple of others like CNMs, I believe it is, and a couple of others.
Yeah, and the reason that we really highlighted these for you was because, you know, we have seen that RPM can be very, very useful to sort of a host of therapy services, including, you know, therapy, behavioral health therapy by a psychologist or a licensed clinical social worker, and, you know, physical therapy and occupational therapy and speech therapy. And we were really hoping that during COVID, CMS would allow those practitioners to use RPM with their patients. They did allow those practitioners to use some other types of virtual care codes that we'll talk about a little bit later. And we asked them in our comments to extend that to therapists, but that they decided not to do that. They declined to do that at this time. And the same really holds true for this next line on the box here. With respect to standalone reimbursement for RPM services when the patient is being served by an FQHC or an RHC. For those who may not know, these are two rural healthcare entities, and they are reimbursed in a slightly different way than sort of under the typical Medicare Physician Fee Service fee schedule. The reason that it is surprising that remote patient monitoring is not eligible for standalone reimbursement for rural patients like it is everywhere else is really twofold. Number one, it seems pretty obvious that rural patients have a lot to, stand to benefit quite a bit by having remote patient monitoring services in place, identifying problems early, intervening early. And the second is that remote patient monitoring is a designated care management service, and CMS has made other designated care management services like chronic care management services and principal care management services eligible for standalone reimbursement. So to keep on, just keep that on your radar screen. It would be, I think, really beneficial to continue the push to allow RPM to receive standalone reimbursement when they're serving FQHC and RHC patients. Okay.
Sorry, Carrie, I'll just add really quickly. I think I may have misspoke. I saw a comment from Paul about podiatrists being physicians. And I think that's correct. I think I may have said that podiatrists are not eligible to bill. So I apologize, I misspoke there. The other thing is someone asked for us to define what a Qhp is. And that's important as well. So I did mention it, but I'll just say it again so that everyone knows. A Qhp or a QHCP is a qualified healthcare practitioner. That acronym is used in the descriptor for Cpt code 99091, and it's really important for that code. For 99457 and 99458, I think it's a little bit more limited to just physicians and non-physician practitioners that can order and bill for it. There's a specific definition of QHCP though that is similar. It's again any provider that is eligible and qualified to bill for E&M codes under Medicare.
All right, let's talk about the FDA, Kaitlyn.
Perfect. All right, so as you may have heard us mention a couple of times, 99454 is a code that reimburses for a device associated with RPM. The rest of the codes, 99457, 99458, and 99453, also require that a medical device be used in order for those codes to be billable. So what is a medical device? CMS has not defined medical device on its own. What it has said is, in order for RPM to be billable, you have to use a device that meets the FDA's definition of a medical device. And that's a specific definition under the Food, Drug, and Cosmetics Act. Essentially, it's a device that is intended to mitigate, treat, cure, or diagnose a disease. So what that typically carries with it, though, are some regulatory requirements. There are different levels of regulatory requirements that apply to a medical device. And there are also some devices that aren't regulated by the FDA at all, in which case they are not a medical device. So this is a really important question that I want to make sure that we drill into just a little bit and make sure that everyone's understanding. There are a couple of ways that you can become a device, or that you can associate a device with remote patient monitoring or with the FDA's definition of a medical device. A software platform can be a medical device, or you can have peripheral hardware devices that are medical devices. You may be familiar with terms like 510K or FDA clearance or FDA approved. For purposes of RPM, those definitions don't matter as much. When we say that a device associated with RPM has to be a medical device as defined by the FDA, we are not saying that the device has to be FDA approved. Those are two separate concepts. One requires a lot of application and some processes to go through with the FDA in order to be able to market your device, while another, there are multiple ways to do it. So for some devices, you can just register your device and fall within a category of devices that already exists. Things like blood pressure cuffs usually fall within there, glucose monitors, some weight scales, all of those devices that you can buy over the counter at your local CVS or Walgreens are typically going to meet that definition of medical device for RPM purposes, but not require additional FDA clearance before you market them or sell them to patients. So that can be really helpful, right? Because that means you can purchase and sell devices that already exist. You don't have to manufacture your own. And you also don't have to spend all of that extra time and money going through the FDA regulatory process if the devices that you're using fall within that class 1 or that category that doesn't require FDA approval. However, that doesn't mean that the devices that you're using for RPM don't have to go through any type of regulatory process. So if you are an RPM vendor and you are purchasing devices from a manufacturer, so you're not necessarily the manufacturer, you don't have to worry necessarily about actually going through the process of getting your device approved or registering it or whatever comes along with that device. You still might have to do a few things. So if you're using outsourced devices, you may have to register under the manufacturer's registration, especially if you are importing devices from overseas. So there are lots of manufacturers overseas that manufacture relatively low-cost devices, which are great. They're very effective for patients. They are very helpful for when it comes to sourcing like Bluetooth devices or cellular enabled devices. There are lots of manufacturers that do this, and lots of them are overseas. What you need to keep in mind though, is if you are the first stop for that device when it comes from China or India or wherever you're getting it, you may have to register with the FDA as what's called an initial importer. There are a few steps for that. It's not terribly difficult, but it is something that you'll want to think about. If you are manufacturing your own devices and they meet that FDA definition of a medical device, you'll probably want to understand, okay, do I have to go through this pre-market approval process? Do I have to get 510(k) clearance? Or do I just need to register my device so that we're showing that it's a medical device, but we don't have to go through these extra steps? So all of that to say, there are a couple of different things that you need to be thinking about when it comes to making sure that you are incorporating an appropriate device. And one area that this can also be really important is if you have a software function that can be a medical device, you'll still need to go through those same processes. Some people think that, or don't realize that if it's a software function, it does fall under the same regulatory oversight under the FDA as a hardware device does. So even if you've got a software program and it's doing more advanced things like diagnosis, or if you've got an AI function in there and that's helping with clinical decision making, you may still have to go through that FDA process. So if you have questions about that, because this is kind of a new area for a lot of RPM vendors, please reach out to us and let us know. We're happy to talk through it with you. There are a lot of nuances, a lot of detail. We have attorneys within the firm that are absolute experts in this area that are not on this call today, but that we're happy to connect you with. But I think the major takeaway from this particular slide is that this is a very important piece of making sure that your RPM program is reimbursable. So whatever you're doing, you want to make sure that you're in line with these requirements.
Excellent. All right, come on here. Slide. There we go. Okay, so the next slide involves privacy and security around remote patient monitoring. This is not something that we've heard a lot about over the past several years, but it is definitely something that is sort of becoming on, getting on the radar of everyone who's involved with remote patient monitoring. For example, the FTC, the Federal Trade Commission, recently released an article aimed at consumers, telling them what they should be looking for medical apps or medical devices to make sure that their privacy is being protected. So this obviously implicates remote patient monitoring. And the National Institute of Standards and Technology, and within that, the National Cybersecurity Center of Excellence, has put together a framework specifically for addressing privacy and cybersecurity with respect to a remote patient monitoring platform. There are guidelines to consider that use a very standards-based approach, that are specific to remote patient monitoring. These guidelines are aimed at ensuring confidentiality and integrity of an RPM solution for the patients that it serves. It is aimed at enhancing patient privacy, and it's also, of course, aimed at reducing risk. So, many of us, when we think of patient data and patient information certainly think appropriately of HIPAA. And many RPM vendors or people who, practices who have contracted with RPM vendors probably have a HIPAA Business Associates Agreement in place if Medicare or another federal health care program is being billed. That's great, that is spectacular, you definitely need that, but privacy and security for RPM goes a little bit beyond that. So happy to talk more offline about that as well. Let's see, Kaitlyn, you want to talk a little bit about these initial market trends?
Sure. Yeah, so now we're going to move into a little bit some of the market trends that we are seeing. I'm not sure if we mentioned this before, but we have a very large number of RPM clients. So we see on the day-to-day many different business models, many different trends popping up here and there. And we wanted to share with you all some of the major trends that we're seeing popping up most commonly in the RPM industry. So first and foremost, I think a lot of the people on the call are familiar with this, but one thing that we have seen since 2020 is vendors starting to develop this fully outsourced turnkey RPM solution. This means that now RPM vendors are not only providing a SaaS platform or only devices or even just the software and the device. The RPM vendors are now starting to take on the monitoring role as well. So back in 2020, you may have noticed that the supervision requirement for RPM changed. This allowed for RPM companies to create this model because it allowed for the clinical staff under 99457 and 99458 to actually provide monitoring services fully remote from the billing provider. So prior to 2020, it was the case that clinical staff that were helping with RPM, whether they were monitoring the data, checking in with patients, whatever they were doing within their scope of practice, would have to be located in the same office space as the billing provider. This was another area that we, along with a lot of our clients and a lot of stakeholders, wrote back to CMS and said that it wasn't really practical and that RPM vendors had to be able to take on this monitoring role as well because physicians were already so overwhelmed and nurses were already so overwhelmed. They just simply didn't have the time to monitor the data as it came in within the office. So in 2020, CMS officially changed that rule to allow for that outsourced monitoring. And I think we have seen this kind of take over the industry in 2020. I think most of our clients that are offering RPM services are offering this fully outsourced model. And it's really helpful for providers that want to implement an RPM program because they don't have to worry about who's looking at the data when it comes in or who's making sure that the devices and the platform are still working. They can essentially outsource all of that unless and until something arises with the patient where the physician needs to be the one to check in. So if you are an RPM vendor and you're setting up this model, there are some important considerations to keep in mind. You'll want to make sure that you are setting up appropriate protocol with your customer physicians and a couple of other things to manage your risk, which I won't take up too much time diving into now. But the bottom line is now you can provide this fully outsourced turnkey solution. It's really becoming more and more common in the industry, and you might want to consider doing this if you're not yet.
Great. So another market trend that we're noticing is very specialized RPM platforms and devices. We see a lot of sort of general monitoring of physiologic metrics like blood pressure and heart rate and insulin levels or glucose levels. And that's great. Those are very relevant physiologic metrics for many conditions. But we are also seeing the development of particular devices that are newly created to facilitate monitoring of physiologics particular to a particular disease state. So some of the things that we've seen are epilepsy. These are some of the disease states that we've noticed that are being, people are coming up with really creative devices and platforms for monitoring. Epilepsy is one, behavioral health therapy is another, physical therapy certainly, and occupational therapy also. Ophthalmology, cardiac devices, even dementia. IBS and Crohn's disease. And then of course, COVID-19 has come about as a very obvious use case for remote patient monitoring during the time of COVID. And we should also mention that for COVID, suspected cases of COVID or diagnosed cases of COVID, the monitoring does not have to be 16 days. CMS has specifically waived the requirement that 16 days of data must be transmitted with respect to COVID patients either diagnosed or potentially exposed to COVID. So keep that in mind. And I'll talk a little bit about this next one as well. So another trend that we're really seeing in the market is a one-stop shop for the various care management services. We mentioned designated care management services a little while ago, and that is a category of services that CMS has defined, and they are generally allowed to be provided under general supervision, meaning that clinical staff members are able to take on a significant role in managing care without being in the same physical location as the physician or the nurse practitioner or the PA. And that has been very, very useful. So the Chronic Care Management Services code set actually came out in 2015. And there have been a number of chronic care management services vendors that popped up to serve practices that were interested in, managing the chronic conditions of their patients. Now what we're seeing is other vendors for remote patient monitoring services, right? Those vendors are popping up. And there are other vendors that maybe specialize in behavioral health integration care management services. What we're seeing is indication from physician practices that they don't really want to have multiple vendors for these services. This is particularly relevant for primary care physicians, but even specialty physicians that focus on a particular disease, chronic disease state that would lend itself well to remote patient monitoring, such as cardiology. These practitioners, these physician practices, really are attracted to a platform that is more of a care management platform than just an RPM platform or just a chronic care management services platform or just a behavioral health integration platform. And the model works the same, right? The company may have capacity to have its clinical staff members do RPM, monitoring the data, do chronic care management services and BHI services and principal care management services as well. And they charge the customer practice a services fee for whatever services the customer practice decides that they want for their patient population. And, as you saw just before on the slide, these other care management services codes include chronic care management codes, principal care management codes, and the distinction there, I should draw the distinction. Chronic care management codes are used with patients that are diagnosed with 2 or more chronic conditions. Principal care management codes, in contrast, came out in 2019, I believe, and they are only required to be used with patients that have one sort of chronic or acute episode going on, one care condition. So that could be a post-surgical use for principal care management. It's a little, it's more broad than chronic care management, and it's probably, as a general matter, more limited in time scope. But it's a nice addition for specialty practices to have, or for practices that do surgery and have sort of a post-surgery recovery period. Transitional care management is, it sounds pretty obvious, but it is care management services provided in the transition of a patient from one care setting to a lower care setting. So from hospital to skilled nursing facility, or from skilled nursing facility to home health. And those care management services are limited in nature, limited in time. behavioral health integration and psychiatric collaborative care, the care model, are two new sort of care management services that are being used in particular with primary care practices. There is a huge movement to integrate behavioral health care into primary health care, bring it more front and center. And these behavioral health integration psychiatric collaborative care codes really are key in facilitating that effort for primary care practices and other practices that are very interested in making sure that the behavioral health aspects of their patient populations are considered as well. Okay, Kaitlyn, you want to take this one?
Sure. Yeah. So this is a little bit broader than Carrie's previous slide about market trends with respect to more comprehensive use cases for RPM. What we're also starting to see is even broader applications of not just RPM and CCM and BHI, but actually tying in telehealth and virtual check-ins and e-visits into that as well. So we'll talk about, well, actually, I don't know if we already mentioned it, but basically there are, in addition to the care management services, there are telehealth codes. Yeah, perfect. So this slide talks a little bit about expansion of telehealth services and reimbursement during COVID-19, remote evaluation of patient-submitted images and video. This is where you may want to send your dermatologist a picture of a rash that you have to get their insight into whether you need to go into the office or not. And they'll, review that picture later on and let you know. That is just another type of virtual communication service that it was created in 2019, but has been used a little bit more often because now when we have remote patient monitoring, which is an asynchronous service, and telemedicine, part of that is kind of that in between where it's not fully a telehealth visit that's required. I don't need to get on and video chat with my patient, with my doctor, but it's also not sufficient for my doctor to just be tracking my blood pressure. I've got an immediate need that I need them to look at. Same thing with virtual check-ins. It's rather than sending a picture, you're now actually doing a very brief pop-on with your doctor via video chat again, or I think it can be a phone call as well. And it's the same thing. You're saying, these are my symptoms right now. Do I need to come in for an office visit, or do you think I'm okay if I just take some over-the-counter medication? So we're starting to see these broader software platforms that tie in the telehealth, that tie in the remote evaluation, that tie in the virtual check-ins, and then also tie in these e-visits as well. So e-visits are this is a type of service that has gained a lot of steam during COVID because CMS has really started to push e-visits as one way for providers to check in with their patients without having them come into the office. So e-visits are a little bit more than a telemedicine visit, but not quite that long-term remote patient monitoring. This is a up to 7-day evaluation by your provider of a condition. So you call your provider one day, or you check in with them via your EHR portal or your RPM portal, and you say, hey, this is what I have going on. And the doctor says, okay, check in with me in 3 days. Then we'll check in again 3 days from there, and then we'll decide whether you need to come in for a full visit or whether you're feeling better. I imagine this would be very useful for COVID patients, especially patients that have been diagnosed with COVID and want to stay home to keep themselves and everyone else safe, but that the doctor still wants to monitor their condition. And I also see a lot of people asking in the chat about the 2-day requirement for RPM during COVID. If you don't necessarily need a full e-visit for 7 days, yes, during COVID, providers can do remote patient monitoring for only 2 days rather than the 16-day requirement. However, that's only for patients with a suspected or confirmed case of COVID. So that is very, very specific to COVID patients, and that's why we didn't dive into it much during the webinar, but I saw a lot of people asking it, so I just wanted to touch on that. So again, the e-visits are that longer, but not fully a 16 or 30-day monitoring period. It's a up to 7 days evaluation and management service. This again takes place via the patient portal. So that's just another market trend that we're seeing, where these platforms are now starting to integrate everything. And also, what we didn't necessarily mention on the slides, but a part of this that I think may start to happen as well is integration with EHRs. Some software platforms are already doing that. Not a lot of them are. I think EHR providers have been a little bit reluctant to just open up their software for integration with a bunch of different softwares. But as we see these kind of broader software platforms start to exist, where now we're kind of moving more fully from in-person visits to more complete virtual care, I think that EHR integration will come in as well. And we're kind of running out of time here, so I want to make sure we get through the next slides. Carrie, do you want to talk about what's on the horizon?
Yeah, absolutely. So at the end of 2020, I believe it was November or December 2020, CMS and OIG issued a pair of final rules that made some very significant changes to the anti-kickback statute and to the START physician self-referral law, the implementing regulations there, that are very, very interesting for digital health and for healthcare providers writ large. The anti-kickback statute and the Stark law were really created around a fee-for-service model of reimbursement. And as most people, I think, on this call realize, my husband is coming in to bring me salad during our webinar. All good. Okay.
Service.
A hand for him. Okay, so AKS and Stark were really created around the fee-for-service model, and the restrictions that they imposed on sort of business arrangements and business models were really sort of messing up the incentives, the alignment of incentives that actually would be very necessary for the types of coordinated care and patient engagement that are going to make a value-based era of reimbursement work. So these changes allow new business arrangements that are going to align incentives for care coordination and patient engagement under the auspices of contractual arrangements that are called a value-based enterprise. This is not something that is a new entity that you have to start. It is a term for the contractual arrangements that create the right infrastructure under new safe harbors to the anti-kickback statute and the Stark law that will allow different types of previously under anti-kickback statute, it would be problematic for a vendor of remote patient monitoring technology or any other digital health technology to provide something to a physician practice at anything less than fair market value. These changes allow fair market value to really not have the same weight that it has in the past. If there is a value-based reason for creating an arrangement whereby a vendor could perhaps provide a clinical staff member to help be the liaison at a physician practice for monitoring remote patient data or providing chronic care management services a couple days a week, maybe in office if that was useful. That is now something that could actually be done. The bottom line is that you want to improve the outcomes of a patient population as a whole, and you want to decrease costs, the overall cost of healthcare as well. So it's sort of the definition of value-based care. The details are complex, but I would love to talk with any of you about some of these really exciting, I think, potential arrangements that can now become available among providers across the spectrum of care, among telehealth companies, remote patient monitoring companies, care management companies. All of these are eligible to be what they're called are value-based participants in a value-based enterprise. And that means that the business, they can also benefit from the business models that they're creating with these aligned incentives. So we will pause for there. Right there. We will take a question or two in just a moment For those of you who are able to stay on the line, we're happy to answer a couple of questions. I wanted to let you all know that our firm is offering an RPM compliance assessment for remote patient monitoring companies or practices. That includes a deep dive on your reimbursement protocols, your FDA regulatory assessment, a privacy and security assessment, a review of the core documents, if you already have core documents in place, terms of use, privacy policies, services agreements, that type of thing, and updating if necessary. And then also, sort of a summary of these changes that have come about in 2021 and some FAQs that you would be able to provide to your potential customers. So if you are potentially interested in that, we have a page on our website that is dedicated to it. I believe that page is going to come up right after we end this webinar. I believe you'll be directed to that page, and you can click there if you are interested. If for whatever reason you need to sign off right now before the webinar has ended, you can go to our website and look at the top tab on I think the latest, and you'll see in the drop down an RPM assessment, and so you can visit that or just contact any of us for additional information. You can use the contact form at our website. We would be delighted to do that. Faisal, were there any burning questions that we did not get to that we should address before we wrap?
Yeah, I was just going to bring one up, but I'm going to be honest to everybody. There were so many questions trying to field, so you might have already responded to this question, but I think it's an important one because the question came in and a panelist affirmatively answered. And so I wanted to kind of roundtable this among the four of us. So the question is, can 99457 and 99458 be billed if you do not have 16 days worth of device transmissions? So I'd love to get your take on it. And then if there's anything to add, I can with respect to kind of an enforcement compliance perspective based on my former experience being on the enforcement side at HHS. I'd love to add some value.
Yeah, Faisal has a very valuable perspective to add on a lot of these questions because he was with HHS in an enforcement capacity, and was looking at, he has a good sense of what the government is looking for if they come knocking and there's an audit. So I think Kaitlyn touched on this question a little bit earlier, but it's kind of a confusing one, so we'll go over it again. It is the case that only 99453 for setup and 99454 for supply of the device can only be billed at such time as when 16 days of data out of a 30-day period have been collected and transmitted by the patient. Now, for the monitoring codes, 99457 and 99458, there's absolutely nothing in the Medicare Physician Fee Schedule or the CPT manual that ties those two codes, the monitoring codes, to a 16-day requirement. I'll be honest with you, this does not make a lot of sense to me, this whole sort of structure around this, but the way the reading is currently in the rule is that if a patient transmits 12 days of data or even 6 days of data, and something in those 6 or 12 days flagged an abnormality, and a clinical staff member called the patient and said, hey, what's going on, and spent some time with them and made a note in the care management. Anyway, if 20 minutes accrues during that calendar month, because those are on calendar months instead of 30-day cycles, then there's nothing to prohibit you from billing 99457 and potentially 99458 if you had another 20-minute increment. It's counterintuitive, not clear sort of why it is this way. We certainly want it to at least stay this way. If we're going to have that 16-day requirement, let's have it only be limited to the supply of the device and the education.
Yeah, I'll just add on to that, right? I mean, from a practical standpoint, you've got the rules. You have the statute, the rules, and I'm looking at this from like an audit standpoint, what you can rely upon if you are questioned. The rules make it crystal clear, as Carrie said, right? It doesn't make much sense on its initial face, but crystal clear, 16 days is tied to 99453 and 99454 only. So you have the rule to rely on. Then you have CMS website materials, FAQs. All of that, again, 16-day requirement, only tied to 99453 and 99454. So even the informal non-legal guidance supports billing for those codes. And then practically speaking, right? Now, RPM program, right? A lot of these patients and the different use cases, you're going to be on these programs for a long period of time. Quite could be, right? Somebody has a serious events, hospitalized, is not on the devices for 16 days, but you're still following up, doing care management. So it makes sense in a long-term arrangement, right? That a provider would be quite justified in billing and performing time on 99457, 99458, billing for that, right? And particularly that month you didn't get the 16 days. So that's the long way of answering. I think there's ample justification for billing it. It's explicit, and you've got implicit CMS guidance as well. So
yeah, and Charlotte also asked a relevant question here. Isn't 99453 a one-time only billable item? The explanation suggests the provider can only bill for 99453 after the 16 days of transmission. So yeah, that is correct. It is a one-time code. You know, it is possible theoretically, again, like this makes a lot of operational or logistic sense, but it is possible theoretically that in the second month of monitoring, the patient will transmit 16 days worth of reading out of that 30-day period. There's nothing to say that, I guess, at that time you could bill for the 99453 since the service presumably was done initially. That's kind of a judgment call, you know, on your part and your billing department's part. It's a little crazy, but it's kind of where we are right now, unfortunately. I also see a question in here about DME, durable medical equipment. The thing to remember about durable medical equipment devices is that it is important not to both order a device and bill it as durable medical equipment, and to bill it under 99454 for supply of the device. That would be considered kind of double dipping in the case of CMS and or OIG, and you don't want to do that. But but it's certainly possible that you could use a device that's provided under DME for remote patient monitoring. We haven't seen any prohibition on that. So we're already a little over time. I appreciate everyone's participation. My awesome team members here did a terrific job. I'm glad we had so many participants. Please visit our website, check out our RPM compliance assessment, and let us know if you have any feedback on this webinar. And we'll talk to you all again soon. Thanks so much.
Yeah, and just to remind everyone, you will get a pop-up that will take you to more information on the compliance assessment. I saw a lot of people asking how much it costs. So just click on that link. It may differ depending on the scope of what you need. We don't really like to do flat prices because we want to make sure that we're only giving you what you need and only charging you for what you need. So click the link, schedule the call with Carrie or me, and we can go over what we need to get done for you, and then we'll talk about how much it might cost. Thank you, everyone.
Thank you.